The calcium score has been getting so much attention lately. I have patients practically begging me every week to order it, and they usually fall into one of two categories. On one hand, you have patients who maybe have high risk factors. Maybe they've been told by their doctor that something needs to change, but they want to see the results for themselves. And on the flip side, you have patients who are super healthy and maybe they're doing everything right, and they want to use the calcium score as a way to prove to themselves that they're on the right track. The calcium score is a great test, but it has some limitations and it's not for everyone. I also think it's a fascinating way to highlight how patients and doctors think about risk. Heart disease is an abstract problem that unfolds over a long time. It's natural that the calcium score has entered the conversation. It offers us a way to get a concrete number to help assess risk for an individual patient. But what that number doesn't show you is the nuances behind the test. I'm here to tell you that certain low-risk patients and high-risk patients should not be getting the calcium score, and I'm here to tell you why. Imagine you're driving your car and the engine keeps on overheating. The service engine soon light comes on, so you take it to the mechanic. They do their diagnostics and they determine that the radiator is broken and that you need a $2,000 fix. Rather than doing that, you ask the mechanic, "Could you show me where the leak is?" That's the same kind of thinking that applies to certain high-risk patients who are asking for a calcium score. We already know the risk factors that cause heart disease. For certain high-risk patients, getting a calcium score doesn't change the equation. And what we should be focusing on is how to fix those problems as opposed to getting more diagnostic information. For some patients, I find that the calcium score is being used as a delay tactic or as a bridge to connect the abstract concepts of heart disease and the concrete reality facing a patient. But what this misses is that the calcium score in certain high-risk patients may be giving them a false sense of reassurance. The limitation behind the calcium score is that it only shows calcified plaque. It doesn't show the dynamic process of atherosclerosis underneath. And for certain high-risk patients, we need to focus our attention on lowering those risk factors rather than getting more diagnostic tests. And on the flip side, for really healthy patients, getting a calcium score is also inappropriate because it exposes them to unnecessary radiation and opens up the door for the possibility of other incidental findings. I can't tell you how often when we get a calcium score that we find some random cyst or some random problem that we need to go on a wild goose chase to find, and it almost never ends up being anything serious. Again, I think the calcium score is a great test and I order it all the time, but its primary use should be in intermediate risk patients. If we're using it in low risk patients or high risk patients, at least we should understand why we're doing it. The calcium score also illustrates how doctors and patients think differently about diagnostic tests. Doctors are trained to think in populations and always to ask ourselves when you order a given test, how is this going to change management? Patients may be thinking about that in some way too, but they're more focused on, do I have a problem? Or what's going on with me exactly at this given point in time? Those are all very important things to do, but when we order a test, especially one that has radiation involved or the possibility of opening up incidental findings, we really need to ask ourselves if this is going to be changing management. I hope this video was interesting to you. I like to talk about observations that I make while taking care of patients and try to refine my thinking process for ordering diagnostic tests. Have a nice day.